Hello and welcome to Live Healthy West Virginia, the podcast brought to you by WVU Medicine, aiming to help everyone live a better, healthier life in West Virginia and beyond. I'm your host, Mary Ravazio Menard. Today, we're talking about thoracic surgery, which covers a lot of ground, including diseases of the chest, lungs, esophagus, and stomach. Do you suffer from acid reflux, a hiatal hernia, esophageal cancer, lung cancer, or lung nodules? These are all conditions that may need to be treated with thoracic surgery. So today we're talking about all these conditions and the latest treatments for them. Many of them are minimally invasive, with Dr. Jason Lamb, Director for Thoracic Surgical Quality at the WVU Heart Vascular Institute. Welcome, Dr. Lamb, to Live Healthy West Virginia.
Thank you, Mary. I'm so glad to be here.
Well, it's good to have you here. Okay, so let's start with one of the more common GI disorders. I understand it's estimated more than half of the people over the age of 60 have a hiatal hernia. So let's start with what's a hiatal hernia and what causes it?
So that's a great question. You're exactly right. More than 50% of adults, probably over 50, have a hiatal hernia. And hiatal hernias in the next topic we talk about, GERD, sometimes go hand in hand and sometimes they're separate.
Okay.
A hiatal hernia is more the physical problem, and we are very well designed as human beings, but there's a couple of things that probably aren't designed perfectly. And the hiatus, or the hole in the diaphragm where your esophagus goes through to connect your mouth to your stomach, is one of those places where we're not perfectly designed.
Okay.
There's a vacuum in our chest, and then we have positive pressure in our belly. And over time, as we age, genetic factors, obesity, pregnancy in women, heavy lifting, chronic constipation, cough, anything that increases pressure in our abdomen tends to push the stomach up through this hole that tends to get looser over time, as many of our muscles do.
Okay, as we get older.
And that can push, yes, exactly. And that can push our stomach up into the chest, which is what a hiatal hernia is. The hiatus is actually a normal hole that's there for our esophagus to go through. And when it gets slightly enlarged, a portion or all of the stomach sometimes can go up through that hiatus.
Wow. Okay. Well, do all hiatal hernias have to be treated?
No, as you mentioned, more than half adults over 50 are going to have a hiatal hernia, and most of those are asymptomatic or minimally symptomatic and treated with even over-the-counter medications, or are not even known.
Yeah. So which hiatal hernias should be treated then, and what are the treatment options?
So there's two reasons why a hiatal hernia might become symptomatic. And that is a graduated level of symptoms over time. Many patients know they have a hiatal hernia and they become more symptomatic with time and then seek treatment, specifically surgical treatment, which is what I deal more with.
Okay.
The first would be that the stomach, a portion of the stomach goes up through this hiatus and it's residing in the chest, and it can make swallowing problems, difficulty with digestion, early satiety, meaning people feel full early. They don't empty their stomach well. Obstructive type symptoms. And in those cases, you'd have to straighten the stomach out, get it back into the right place, and fix the hiatus, make it tighter again, such that nothing goes back up there. So that's one. One is mechanical or obstructive.
So if we have those symptoms of like pain, will you feel pain if it's?
Some people feel pain in their kind of epigastrium, which would be the middle between your chest and your abdomen as the stomach tries to push up. I always tell patients that it's, if you can imagine pulling a towel through a napkin ring, you pull the corner of a towel up, it comes easily, but as the towel gets thicker, the middle of the stomach, it gets caught. And that can cause pain, as you mentioned, or it could cause obstruction or a functional obstruction where food hangs up as it tries to go through. And those patients might regurgitate, they might feel full early, they might bend over to tie their shoes after a meal and have something come up into their mouth, either gastric juice or food, etc. So those would be the obstructive kind of symptoms.
Okay.
The other type of hernia that we often deal with is that causes reflux, and I think that's next on your list to discuss, and it'll lead us. Yes, it'll lead us right into that.
There we go. Well, speaking of that, well, before we talk about GERD and reflux, is there anything we can do to prevent a hiatal hernia?
So yes, there are some things. An increase in abdominal pressure, which would be caused with the types of kind of activities I mentioned, constipation, chronic cough, obesity, pregnancy in women, anything that increases pressure like that, heavy exercise can make that more likely. So if people have any of those that are correctable, such as constipation, those things should diminish your risk. We can't diminish the aging changes that we all go through, and the muscular weakness we get as we age, and tissues that aren't as tight as they used to be. But some of these things that would increase that pressure to make it more likely can be changed.
Well, good to know. All right, so we're talking about hiatal hernias can actually cause the next topic we have here, GERD and reflux disease. So let's talk about specifically what is GERD and reflux disease and what causes that.
Yeah, so you're very right that hiatal hernias are often associated with reflux and GERD, which are one and the same. GERD is the medical term, gastroesophageal reflux disease.
Oh, okay.
And what patients would feel as a symptom would be something like heartburn, or burning in their mouth, or reflux at night into their mouth or up into their chest and causing pain. Hiatal hernias are in concert with that often, because as the stomach moves up into the chest, it's a lot easier for things to move up into the esophagus. And it's an important problem because long-standing reflux can be dangerous for our esophagus. Our stomach lining is built for acid, and our esophagus is not. So acid reflux very occasionally is not a problem. Most people have that. And if we test normal subjects, they have some acid reflux. It's actually good for the esophagus. But when it's exposed to acid all the time with heartburn, it can cause precancerous changes and even cancers.
Oh, right. Well, that's not good. We don't want that. So that's what happens if it's left untreated. It can lead to cancer, right?
Right.
Okay. So what are the treatments for GERD and reflux? I mean, because this is a pretty common
It is a
condition.
really common. I mean, we all have friends that have these problems, or we have them ourselves. Now, thankfully, there's really good medical therapy. And for those who fail medical therapy, there's surgical therapy. Medical therapies can be over-the-counter things with mild reflux, such as Tums, Carafate, Sulcrafate, coating agents that go down and kind of help coat the esophagus. That would be in mild, where you or I would go out and have a dinner that's spicy food, and occasionally we get some reflux.
Yeah.
Over-the-counter medications such as omeprazole now can be purchased without a prescription. They're in a little bit lower doses than the prescription dose. They're called proton pump inhibitors, that class of medications. And those medications are very, very successful at blocking the acid pump that makes the acid that then washes up into the esophagus, and they're really good for symptomatic control. If your problem is worse than that, you go on to prescription medications, and then the next step would be that maximal medical therapy does not control the problem, and then those patients would be someone, especially in concert with a hiatal hernia, that we might entertain a surgery for.
So what kind of surgery would you do for reflux?
Yeah, so these are pretty common procedures as well. So those who fail medical therapy, and we never take just a hiatal hernia or some mild reflux and do an operation or consider that. It's always done through medical therapy. But someone who has the first problem, a stomach that's completely up in their chest and has obstructive problems, you need to get that straightened out. No medication is going to fix that problem.
Yeah.
The second is if they have significant reflux to where they have changes in their esophagus associated with that, or they've maximized their medical therapy, then we would also fix the hiatal hernia, get the stomach back down into the abdomen where it belongs, and then we do a fundoplication, and that sounds like a long, scary word.
Yes.
All medical
What's that?
All medical words are Latin in base, and the fundus is the top part of the stomach, and to plicate something means to stitch it. So we bring it back down into the abdomen, and then we take the very top of the stomach and you just wrap it around the bottom of the esophagus loosely, such that it gives a little bit of extra oomph to that valve to keep acid from coming up when we're laying down or when we've had a meal and our stomach's full.
Okay. All right. So there is hope. That's good. That's good. All right. But something more serious, you mentioned, you touched on a little bit, like if you continually have reflux and you're having too much acid in your esophagus, this could lead to esophageal cancer?
Yeah, so early on it causes inflammation in the esophagus. We have a lining in our esophagus called a squamous lining, and that lining is not really built for acid. So as the acid washes up there, and these are people with many, many years of acid reflux, much older than us. But no, we're seeing it younger and younger now because people often don't know they have it. Your body changes the lining of your esophagus to a different lining. It's a lining that's seen in the intestine or the stomach. So that's called Barrett's esophagus. You may have heard of that. Many people have heard of that. And Barrett's esophagus is a different lining such that you don't feel the changes because it's built for acid. The problem with it is you have a repeated injury and then a repair, injury repair, as this acid washes up into the stomach or out of the stomach into the esophagus, and it can over time cause a cancer to form. Luckily, Barrett's esophagus, which isn't uncommon, doesn't form cancer very often, about 1% of the time. So just because someone would be diagnosed with reflux in Barrett's esophagus doesn't mean they're going to get cancer. And in fact, 98 to 99% of the time, you're not going to. But it does mean you need to be plugged in to be surveyed every 2 to 5 years and make sure that's not progressing, and then have your reflux dealt with maximally.
Okay, good to know. All right, but what if it does lead to esophageal cancer? How do you treat that?
So that's a whole nother topic.
Yeah.
And I guess I'll first mention that esophageal cancer used to be a cancer really isolated to people that were heavy drinkers or heavy smokers, and it was in the upper esophagus called squamous cell carcinoma. And now over 90% to 95% of esophageal cancers are in the lower esophagus related to this Barrett's, and they're called an adenocarcinoma. So it's completely changed over the years. If we talk about the lower cancers that develop from reflux, which is what today's topic is really about, those are diagnosed, and if they have not spread outside of that area, the most common treatment, if that's diagnosed by a scope or something like that, where people are having trouble swallowing, then we would treat that with usually chemotherapy and radiation therapy. Both are kind of a little lighter than if they were done independently up front. And then a surgery to take out that portion of the esophagus and upper stomach. It's all reconnected, and then sometimes chemotherapy or immune therapy afterwards. So it's a big deal.
You can take out part of your esophagus and it's, still everything can stay connected?
Yeah, the human body's amazing. There's enough blood supply to the stomach. We can kind of keep the bottom half of the stomach and we make a tube out of it. And we can take the lower half of the esophagus out and we can pull that up through and connect it together. You don't have as much storage like a stomach, which can store food.
Yeah.
And typically those patients, after they recover from surgery, may lose 15 to 20% of their weight long term. But yeah, it's a successful surgery that we also do minimally invasive often.
Wow, that's interesting. What can we do to prevent getting esophageal cancer?
So the best way to prevent esophageal cancer is to manage the symptoms of reflux well. As I stated, over 90% of esophageal cancers are related to reflux and the formation of Barrett's esophagus from heartburn. So managing that with medications, or if medications are not effective, to consider a surgery, be it a fundoplication if needed. The other way to manage that is make sure that if you do know you have Barrett's esophagus or severe reflux, that you're seeing a gastroenterologist or someone who can do an endoscopy, a surgeon, that can do biopsies. Those biopsies, based on what grade of the Barrett's esophagus is in your stomach or in your esophagus, are done between 6 months, 2 years, and 5-year time periods based on what's found. So once you get into a surveillance program, as long as you're being followed routinely, we should catch that early enough that there are good options.
Good to know. All right, well, we're gonna switch gears to, we're gonna move up now, or maybe not up.
Over, move out.
Over, yeah, we're gonna move over. We're gonna talk about lung cancer, which is the second most common cancer in West Virginia. That's so sad. And accounts for 18% of all new cancer cases in West Virginia. So let's talk about what exactly lung cancer is and what's causing it.
Yeah, so we moved to a really common cancer. I should say, and I'd like to mention on the esophageal cancer, that if someone has reflux or they have some mild symptoms of trouble swallowing, it's not usually esophageal cancer. Thankfully, it's one of the more rare cancers. It's not as common as some of the other ones. Lung cancer, as you mentioned, is the second most common cancer, not only in West Virginia, but in America. Second to breast cancer in women, and second to prostate cancer in men. The main reason for lung cancer is smoking. People that do not have a smoking history do get lung cancer occasionally, but not at the same rates as people that smoke.
Why is that? How does that happen?
Hard to know. There's a lot of things that go on in cancer now that we're starting to get a hold of with immune therapies and things like that, where our immune system doesn't recognize certain cells and that sort of thing. So we'll find some of that out over time. Interestingly, the state that first had a fall in lung cancer rates was California, which was the first state to adopt no smoking policies in public places. So we've seen the rates come down. And interestingly, historically in lung cancer, after World War I, when soldiers were given cigarettes as part of their rations and then became addicted to nicotine, men's rates went up. And then after World War II, where women often worked in the factories and stuff and had access to cigarettes, their rate went up, and now both rates are coming back down after the smoking cessation law. So the smoking cessation things that have gone through really do help with the development of lung cancer. It's very well associated with it.
Okay. So that's what causes it. So
now you ask why in West Virginia?
Well, yeah, why in West Virginia?
Well, the biggest reason in West Virginia is that the smoking rates have remained high in West Virginia compared to other states. They're not high overall in that everybody smokes, but the smoking rates are higher than some of the other states.
They're not typical. No,
right.
We're number one in too
things,
many things that we shouldn't be number one in. That's why we're doing this podcast. So anyway,
now the best thing with that is smokers who have had a long exposure to cigarette smoke, and many coal miners, you'd think they worked in a very dirty environment, but when they came out, the thing they enjoyed was a cigarette. I mean, anyone who's tried a cigarette or has used cigarettes will all tell you that they enjoy cigarettes. Because we have such a high rate of smoking, we've now developed lung cancer screening programs. And West Virginia is a difficult state to take these things to the community because there's not big areas or big populations in one place. So specific to this state, we've developed a program where a CT scanner is in a mobile van that goes out to the communities. And it's now, after a long study with the national studies, we found out that certain smokers between age 55 and 79 who've had more than 2 packs a day for 10 years or the equivalent, so 20 pack years history, and have stopped smoking within 15 years or are still smoking, they all qualify for a yearly screening study with a CT scan. So that is really changing, finding these people earlier. And I would advise anyone that listens to this podcast or has family members or friends to get access to those programs through their primary care doctors.
I'm glad you brought that up because that's only been around a few years.
That's
Lucas.
Yep,
yeah,
the Lucas
it's a
program.
great
Exactly
program.
right.
It's a great program, and we're certainly making good use of it here.
And the idea is to find things. The other thing when you have trouble with some access to care is the cancers seem to get found later on, right?
Yeah.
People in West Virginia are tough people. They don't like asking for help. And they're in remote areas often and have significant risk factors. And all these are good things until you have a lung cancer. And the more you delay when you have a lung cancer getting in to see someone, the less survival and the less opportunity for change you can make.
Yeah. So how do you treat lung cancer? You
So
have to catch it early, don't you?
That's the best way to treat it, the best way to cure it. There's a lot of ways now to treat lung cancer that didn't exist even 15, 20 years ago.
Really?
Yeah. So surgery has always been a way to do it, but we're doing it less and less invasive now. We do it through a VATS approach, meaning through small incisions where we just make an incision big enough to get the piece of lung out that we're trying to operate on. We use robotic approach, which is very similar. And we avoid the bigger incisions between the ribs that historically were quite painful. We're able to do smaller and smaller portions of the lobe or the lung in those patients that have had emphysema, which often goes hand in hand with their smoking history. So there's better surgical ways to treat it. There's also in patients who don't have enough lung function or heart function or there are other medical problems would prohibit surgery, we can treat with radiation that's focused right at that spot. And then there's newer therapies such as immune therapy that have come out that are really groundbreaking in lung cancer.
Yeah, they're really making some good progress with immunotherapy,
I mean,
aren't
groundbreaking, yeah. And every day there's new medicines that are coming out aimed at certain factors on the cancer cells that don't exist on our other cells that help our immune system, our own immune system, identify those cells and then kill those cells.
Wow. Are there symptoms for lung cancer? I mean, do you really have a way of knowing unless you have a scan?
Mary, that's the main problem is by the time you have a symptom from lung cancer, it's often too late to do much about it other than palliative therapies. Now, some of those are very effective, but if you have pain in your chest or you cough up blood or something like that, or you're more short of breath, they're often fairly well advanced at that point.
All right.
So the best way is through screening.
Go to your doctor and get screened.
Well, it's true of everything if
Yeah.
you think about it, right?
Absolutely.
Colon screening, mammograms, lung cancer just is going to fall into that.
Yeah. Yep. Okay. Now, you also wanted to talk about lung nodules. What are these? And, are they common and do they cause cancer?
Yes, yes, and yes.
Oh, good.
Yeah.
Great.
Great. No, so lung nodules go hand in hand when we screen for lung cancer. So I'll give you an example of the population we're screening is a heavy smoking population. They do a low dose screening study. And in those big national trials that had Medicare pay for these low dose screen, they found that 75% of the people with that exposure history had a lung nodule. Right? Okay. Now, a lung nodule is just a kind of solid growth in the lung. Our lungs are usually spongy and have blood vessels that take blood in and out of the air sacs where we exchange gases. We breathe non-sterile air all the time. Things go in and we might react to those. We might get a pneumonia. We might have an inflammatory disorder, anything. You might ingest a foreign body that gets into the lung, and then you form a scar around it and you make a little nodule. Of all those screened with that background, 75% of them have lung nodules. So our patients get very terrified when they get a screening CT and they say you have a lung nodule. Automatically, they think they have a cancer. Thankfully, only 1.6% of those screened have a cancer. So 3/4 of the patients have a lung nodule and only 1.5% have cancer. So that leaves a lot of people, 73% of those screened, that we have to follow up with CT scans and make sure those nodules don't grow. We live in an endemic area for histoplasmosis and blastomycosis. These are fungus and molds that grow in the air. It rains all the time here, as you know. Yeah. The Ohio River Valley has got a lot of wet soil, and we have these things that float around in the air. As you know, you can put dough out on your windowsill, and it'll get yeast and rise.
Oh, really?
Yeah. There's a lot of stuff in the air around here. Yeah.
Okay.
So we have patients that are exposed to a lot of stuff. Industry, coal mining, the stuff in the air, and these things can make nodules in the lung, and they can also make lymph nodes that are around the airway tubes and in the lung. And all these things become scary when people are getting screens. So the screen, if you have a nodule, doesn't mean it's the end of the world, just means it needs to be followed closely, just as we talked about with screening endoscopies.
Okay, so we just need to watch. Any way we can prevent?
The lung nodules?
The lung nodules living here?
Yeah, well, we know if you screen a non-smoking population, they have much less chance of nodules. Now, because you're ingesting not just the cigarette smoke or the nicotine, you're ingesting a lot of stuff that's going down in your lungs and you're reacting to.
Yeah.
So not smoking is probably number one.
Okay.
Other than that, we all live around here and you breathe some of the stuff that's in the air.
Yeah, okay, good to know. All right. So we've covered all that ground. I want you now to talk about the expertise of the thoracic surgery team at the WVU Heart Vascular Institute. So we've got heavy hitters here, right?
Yeah. As you know, we have a great group over at the Heart Vascular Institute, and that incorporates cardiology, interventional cardiology, cardiac surgery, vascular surgery, and thoracic surgery. And we have a great team. It's under the direction of Dr. Badwar, who came down here, I think, in 2016 or 15. Yeah. And the volume has grown tremendously since that time. We have a great group within the thoracic division. And what we deal with is some of the topics we talked about today. Really disorders of the chest outside of heart surgery. Everything else that's in the chest kind of falls into thoracic surgery. So we have a great group of people, a great group of extenders, PAs, and nurse practitioners that help deliver care. We're happy to see anyone that has a question or a concern that would lead to anything.
All right, that's great. Okay, so before we go, I always like to ask, what's the most important thing you want our viewers or listeners to know about thoracic surgery and treating thoracic diseases and disorders?
The most important thing is if you have a concerning symptom, reach out. Because all of us don't want to reach out early, and
because we think it's going to go away.
Yeah. Yes, exactly. Yeah, and I'm the same. Us doctors are the same. Everybody's the same. Yeah. But as we get older and you have trouble swallowing, or you have some concerning cough that doesn't go away with an antibiotic course or something, don't just muscle it out. Reach out. Get a follow-up test, ask your primary care doctor to get a CT scan or something that's going to elicit a better look into what's happening.
Okay, great. Well, thank you for sharing all this information with us. We covered a lot of ground, and I think we helped a lot of people. I mean, we had a lot here on the list, and I think we did good.
I'm so glad to be here.
Well, thank you.
Thank you for the invite.
Thank you for coming. We appreciate it. Well, that brings us to the end of this edition of Live Healthy West Virginia. If you're looking for more information about thoracic surgery, you can always visit wvumedicine.org/thoracic. And to find the latest episode and all episodes of Live Healthy West Virginia, visit wvmetronews.com/podcast and the all-new Metro News TV app. I'm Mary Ravazio Menard, and on behalf of Dr. Lamb and everyone at WVU Medicine, thanks for joining us.